Well, I mean, we don't have a lot of choices. I mean, if a man doesn't have testosterone, the best way to replace it or to increase it is to give him testosterone. There are some medications that stimulate your own production of testosterone, and they're, an alternative, but they don't get you up to the levels you can get to and the ease of adjustment that you can get with injectable testosterone or even oral testosterone. The focus of my presentation at this meeting was the use of testosterone in men who still want to have children. And that's kind of the angle for this presentation, because when you take testosterone, it turns off your own testosterone. Testosterone is extremely important within the testicles for sperm production. And if you take something exogenously from the outside, you get high serum levels, but it turns off your intratesticular testosterone, which is where your testosterone comes from. It comes from something called the Leydig cells in the testicle. And since that's so important for sperm production, if I were to give you testosterone, within 10 to 14 days, you would start seeing a drop in your own sperm production. So the focus of my presentation was how we can allow men who have to take testosterone because their own is very low, they're very symptomatic, they feel so much better when they're on it. Can we allow them to still take it and still remain fertile? The overarching theme is that to make testosterone from the testicles, you need two hormones from the pituitary gland. One is called FSH, and that is called follicle stimulating hormone, borrowed from the women's vocabulary of ovarian stimulation. But this hormone, present in both men and women, in men stimulates the nerve cells within the testicles to help support sperm production. Even more important, or as important, is something called LH, luteinizing hormone, again relating more to female follicles. But in the male, what it does is stimulate the Leydig cells in the testicles to make testosterone. We now can give an individual both LH in the form of HCG, human chorionic gonadotropin, as well as FSH as injections. So we can re-stimulate sperm production despite the fact that it's been turned off by the individual having to take testosterone. So that's very neat now that we can do that. We do it primarily by using these chemicals, these pharmaceuticals through compounding pharmacies because of the cost savings to patients. The brands are very, very expensive. Compounding pharmacies can make it throughout the United States. They're in the current debate with the FDA whether or not the FDA is going to continue to allow them to make it, despite the fact that it's been going on for 20 years. Suddenly they decide, well, maybe pharmacies shouldn't make it. I personally think it's because of pressure from big pharma, who would rather make it than have compounding pharmacies make it. But the cost from a pharmaceutical grade big pharma drug is 4 or 5 times what you have to pay at a compounding pharmacy for the exact same medication. So we are now using the compounded versions unless an individual has insurance that will pay for his brand, but it's very unusual that happens.